Hello and Assalamu alaikum. My name is Danish Bhatti. I'm a neurologist with subspecialty training in movement disorders. I am originally from Lahore, Pakistan, and graduated from King Edward Medical University. I did my residency and training in movement disorders at University of Nebraska Medical Center and was there for many years directing the Parkinson's Disease program and being the associate program director for the Movement Disorder Fellowship. At that time, I started this online fellowship, mini fellowship in movement disorders for neurologists all across the world, especially for Pakistan. And I ran that for 5 years. And last year, I finally moved from University of Nebraska, and I'm currently in University of Central Florida in Orlando, Florida. And currently, I am working with the College of Medicine at University of Central Florida for students teaching. And then I am currently working with research on artificial intelligence and medical devices. And then I have interest in healthcare startups. And I would show you one of my projects towards the end of the presentation. So I wanted to take some time to introduce movement disorders and some advances in neurology to you, to give you an idea of how fast the things are changing and moving in neurology, and what is movement disorders, and what are the new exciting things about artificial intelligence in medicine. So let me share my screen and talk to you about some of the things that we're doing. It's a short presentation. So I am going to look at a few of the advances in neurology to give you some idea of how things are changing. I will explain to you what is movement disorders and how to approach a patient with movement disorders, and describe some of the newly approved non-invasive medical devices available for Parkinson's disease specifically. I have no conflict of interest for this talk, except for the one thing I would show you at the end will be my own startup, which is quizmd.ai, which I have direct involvement in. I would like to dedicate this talk to the memory of my father, who wanted me to do more teaching and education and be an educator and give back to Pakistan. So movement disorders is a study of involuntary movement. So neurology deals with many neurological problems. And in neurology, you can have a problem of not enough movements, like strokes or MS and neuropathies, or too much movement, which is dealt by the movement disorders like tremors or shaking, or the muscle spasms or tightness, we call dystonias, dance-like movements like chorea. This is actually 4 still images from one of the early patients described with chorea, likely from Huntington's disease. So here's an example of how we can make a huge impact on patients with movement disorders by appropriate diagnosis and treatment. So this is a patient from Pakistan that I consulted on during one of my trips. The patient has severe jerky dystonic movement. He's a laborer from a small town in Pakistan. And on his return back from Middle East, where he was working, he developed this problem acutely and was not responding to treatment. You can see a lot of jerks and pulling of his head backwards, arm jerking, posturing. This is something we typically call dystonia. Dystonia can be fixed posturing or could be variable. Most often it's variable and can have jerky movements with it that we sometimes call dystonic tremors. Description and dealing with these kind of movements is what we call movement disorders. And once you diagnose these patients appropriately and make the right treatment choices, you can make a huge difference in their life. And this is this patient after treatment that we prescribed to him, and significant improvement on his movement, as you can see, after 3 months of appropriate treatment. So movement disorders are very common. Neurological problems in general are very common, but 20% of life loss are from brain disorder, 25% of life and daily activities loss. And among neurology, we hear about strokes and seizures all the time, but movement disorders themselves are very common. 3% of patients, 3% of people in the world will have essential tremor. 4% will develop Parkinson's disease in their lifetime, so 1 in 25. And then another 4% have some form of a tic disorder. Tourette syndrome, many grow out of it, but you can find tics very commonly. So just you take these 3 conditions, essential tremor, Parkinson's disease, and tic disorders, that's almost 1 in 10 people who are at risk of developing this in their lifetime. Movement disorder comes from very specific area of the brain. So this is a coronal section from the brain. You can see the lateral ventricles here and corpus callosum on the top of it. and you can see the two halves of the brain on the inside. This is the insular fissure of the brain. And deep here, you see this gray matter, which is called basal ganglia, or collection of deep white matter. And then there is the internal capsule going through it. And then there's the rest of the basal ganglia, which looks like a lens and is called lenticular nucleus. So it forms of globus pallidus and putamen, and the basal ganglia is the thalamus, in addition to putamen and globus pallidus, and then caudate, which is a C-shaped structure running here, and then you have the subthalamic nucleus and substantia nigra. So these are basically the areas where all the movement disorder abnormalities are coming from. Here is one of the most common movement disorder evaluated by one of my mentors and colleague, Professor John Bertoni, who retired last year, one of the landmarks. So his patient setting, you can see a tremor in his right hand that gradually started, now starting also in left hand. As he moved his left hand to posture, the tremor disappeared, which is very typical for resting tremor. Whenever you move the limb, the tremor goes away. And right here, as he moved his hands to gesture, the tremor disappeared and then gradually comes back. Very typical. And then when on examination, what you look for is decrease in movement. With this expression, movement went away. And as he holds his hand, slowly the tremor starts coming back, but the movements will keep it back. And then what we look for is slowness of the repeated movements. When they do finger taps or hand open close, you can compare Dr. Bertoni to the patient. You can see it's much more smaller and irregular. His face shows decreased expression. His lips are parted. Mouth is open. He's not crossing his legs. He's not using his body a lot. His hands opening is not as good as Professor Bertoni's opening. So that is kind of what you look for in Parkinson's disease. And then as Parkinson's disease progresses, you can see gait impairment. Here patient has very short steps, is hardly lifting them off the ground, what we call shuffling feet. The body looks frozen. He's stoop posture. And when one of my other mentors, Professor Daniel Merman, is going to check his postural reflexes by pulling him back, you will see the patient has no postural correcting reflex, and he just falls back straight down as he pulls on the patient. The patient has no correcting reflex. So Parkinson's disease, many of you probably know, comes from substantia nigra. Substantia nigra is this black substance in the brainstem, in midbrain, and the loss of this substantia nigra results in Parkinson's disease, like this patient here. This black substance comes from, the black color is from the melanin pigments in the neurons. These are neuron cells. And what's damaging them is the presence of these pink bodies, which are called Lewy bodies, which is accumulation of alpha-synuclein. And we know that alpha-synuclein starts at the lower end of the brainstem and gradually progresses to the top. And that's why sleep problems and loss of sense of smell is the early presentation, followed by motor presentation. And then finally, many patients develop cognitive impairment, as many as 50 to 70% of the patient. Imaging can help you. So this is, of course, an autopsy study where you can diagnose it for sure. But imaging modalities are becoming very good in trying to pick up the diagnosis. This is iron-weighted 7 Tesla MRI. This shows you this Mickey Mouse kind of a face, which is midbrain. You have the red nucleus and substantia nigra. And when you look for, are these losses in the nigrosome or cut off or mouse-eaten cheesecake kind of a appearance, which is significant for Parkinson's disease. Another way to do imaging is to use radioactive imaging, taking a radioactive compound and tagging dopamine receptors. And this is called the DAT scan, or dopamine transporter scan, which tags the D2 receptors of dopamine. And loss of these receptors in this patient with Parkinson's will tell you that this is normal, and then this loss of the tail of that comma, and this comma is from putamen and caudate, which are rich with dopamine receptors because of the release of dopamine. Parkinson's disease slowly progress over time, both motor and non-motor symptoms, as they have continued loss of dopaminergic neurons. And many invasive therapies have come along recently, and they are becoming more and more common, even now available in Pakistan. This is called deep brain stimulation surgery. You put wires in the deep part of the brain, either in the subthalamic nucleus or in the globus pallidus, and then you hook it up with a wire that runs under the skin, goes down the neck, and connect with a battery in the chest that continuously stimulate that part of the brain, blocking the symptoms of Parkinson's. And that wire in the brain has to be very perfectly placed within 2 millimeters of accuracy, and that requires a stereotaxic frame to put that wires in. And once it's in, you can do many different selections on that wire to provide electrical stimulation in various different ways. These are two different devices. This is Abbott device. This is the Boston Scientific. Both are available in Pakistan and have been implanted, as far as I know. and you can see this electrical stimulation bulb or current around the end of that tip of that wire, which can block the symptoms of Parkinson's. Many medical devices in Parkinson's disease have been approved or under study. This is a comprehensive list. You can get the slides afterwards and look at the list. I'm not going to go through all of it right now, but I will show many of these later on, especially the non-invasive one, which will be my focus for the talk today. So the non-invasive devices can be very bulky and big and require placement in a hospital or a clinic location. So these are some exercises, external robots that are used for therapy, for balance and gait training. And similarly, you may have these treadmills, which are 360-degree treadmills with VR or virtual reality, where a patient can have different kind of virtual reality-based exercises for rehabilitation for Parkinson's and gait training. However, what I want to focus on is something that you can do at home, and home-based monitoring and evaluation of patients is becoming a big deal, so that the patient doesn't have to come in, and you can do monitoring more continuously 24/7 throughout the week rather than a 30-minute or a 45-minute visit. This startup was looking as to see if the videos of the patient can be tagged to look for early signs of Parkinson's disease and have AI diagnose Parkinson's early on by just looking at the patient's videos. So at-home patient devices can be either a monitoring device, a remote patient monitoring or RPM is becoming a big deal, or it could be a non-invasive intervention therapy that patient can use at home. I'll show you examples of both. So when you are monitoring patient at home, the devices are picking up the normal activity and trying to classify it. So it's trying to figure out when is patient lying down, when do they sit up and get up, when do they stand up, when do they walk, when do they exercise, when do they fall, and those kind of things, markers they're trying to pick up from various wearable sensors, either mechanical sensors or electrical sensors, so that, or even a video camera watching them, so that you can diagnose at home and monitor them. One such example is this device called Stat-On. It is mostly accelerometer based that patient wear at his abdomen like a belt. And you can see at color coding, it is trying to classify when they are bradykinetic or slow, when they have tremors in yellow, and then in green, they're normal. Other devices trying to do the same thing. This is Kinesia 360. It has usually 2, but can be up to 4 sensors, one at the wrist, one at the feet, rather than the single sensor of Stat-On, which is at the abdominal belt. So there's a different approach. And again, it has an app that can then track. You can see that finger monitor right there, and you can have an ankle monitor along with it that you can pair. Another approach is this PD monitor, which is again 2 wrist wearable sensors on both wrists and is predominantly monitoring it through that. And then last one that I'm going to show is the one that I have personally used on patient. This is called PKG, or personal kinetograph. It is a simple watch which has a built-in accelerometer that patient wears on their hand, and it monitors their daily performance over 7 days and takes an average. You can see the up and down of Parkinson's patients when they are doing good, and then they're doing bad. They take their pill, then they become good again, and they're bad as the pill wear off. And you can also look at the distribution of the tremors. This is the tremors as black lines. So all those times when the patient is about to take his pill, the tremor comes back, and also adds the immobility of the patient around the same time of his pills. Similarly, in addition to monitoring at home, you can do non-invasive therapeutic interventions, and there are many different approaches that are being done for Parkinson's and tremor. Here is a list of devices. CALA-1 and CALA-TRIO is one approach, which is electrical stimulation of the nerves. Motive is an electrical stimulation of the muscle. Then there are mechanical stimulations, either as a tremor glove or vibration bracelet that I will show you in a minute. This is CALA-TRIO. It's FDA approved, is available. The base basically has these 2 electrodes that you put on the wrist, and then it stimulates your radial and ulnar nerve. The radial and ulnar nerve are stimulated by this electrical stimulator that give pulses of stimulation. Sometimes that is synced with the tremors, and then that is supposed to give a feedback to the brain and break that tremor. The other approach is to stimulate the muscles by something that you wear on your forearm. And this electrical stimulation can be out of phase or out of sync with the tremor. And that's how it can cancel out or block the tremor. And if another approach is just a mechanical approach. So this is, I have not used it. I've tried looking for it, but haven't been able to get it. Maybe it's available in Pakistan. What this has is a rotating heavy metal disc. So a metal disc that rotates, spins heavily. And what it does is that when you wear it on your wrist, it stabilizes your wrist. So your hand doesn't shake as much. And it seems to be very effective in dampening the tremor, as you can see with the device off and the device on. It dampens down tremor mechanically. Similarly, you can cancel the tremor by having a motor that moves opposite. So the spoon has a motor inside, and the tip of the spoon can move. And there's a computer that senses the movement of the hand with a tremor and asks the tremor to move the spoon the opposite direction. So your hand is shaking, and the handle of the spoon is shaking in your hand, but the tip of the spoon stays steady and does not move. This approach I've not seen again used personally. This is report where you can have small vibrating discs in the fingertip, and a tremor will detect and cause vibration in the fingertip through these computers on the wrist, and that, or on your gait, on your belt, and that will cancel your tremor. Similarly, uh, other approach is related to gait. Gait is being looked at in ways to improve, and one of the improvement is by giving them these external stimulation. So it could be an auditory or visual stimulation. This one, Q-Stim, for example, provides an auditory stimulation to try to break the freezing of the gait or irregular movements from their walk and improve their gait. Another approach is to give visual stimulation. So these shoes have these laser discs that are put on the toes, and as soon as your foot steps down, it creates a line, visual line, that the patient can see, and trying to step over the line with the next foot creates reduces the freezing of gait that will happen. And similarly, audio stimulation, again, sync with their feet and gait, can also help improve the gait and freezing of gait in Parkinson's. And then lastly, another way to give the visual stimulation is by having a laser in your cane, and then a button or a sensor that can be in sync with your foot. And as you walk, it can give you a visual cue, and you step over this visual cue to try to break your gait or freezing of gait in Parkinson's. One recent one that have been interesting finding was that giving a whole body vibration, in addition to the fingertip vibration I showed earlier, can also be useful. So you can have patient stand on this machine that vibrates, and is being used for general health improvement, but has shown to be helpful for improvement of tremors, improvement of gait and balance, and posture stability. So I gave you some idea of the devices that are out there and are creating innovation. You can see that most of the ideas and the devices that are out there are not so technologically complex, and that is something very easily doable even within Pakistan. And you should be creative. You should look for things that your patient tells you or you observe as things that help your patient, and then come up with ways to try to create some device or a solution, and try to create a prototype, or create or break those barriers of creating innovation that can be done anywhere, in even in Pakistan. We have done many startups around this idea to try to promote the innovation. I will mention two startups. One of them is Revive Medical Technologies. Revive Medical Technologies basically a tool to try to provide a platform to try to do some of those device innovations at home. So what we are trying to do is to find ways to give a place where physicians can go get their ideas tested or implemented. We're trying to provide ways to give them support for launching a startup or a company around it. And one such platform that we have created is called Revive Medical Technologies. Let me quickly show you a few slides related to that. This is just a place which we have created to try to give some space for physicians to be able to come and get their device tested. So we have technologies for design and simulation, 3D printing, electronic labs. This is based in Rawalpindi. And PCB printing, machine learning. These are engineers who you come with observation or ideas or a solution that you have come up with, and they can help you figure those out. And many other technologies are coming. And then this is in Pakistan that is being done. Another thing that I wanted to quickly show you was a project of mine that you can also access. It is called quizmd.ai. We're using the AI or artificial intelligence for medical education to help you create questions very quickly. So multiple choice questions is a big barrier. We have to spend a lot of money or find these, sources of quiz bank to practice or get our training. So one thing I wanted to show you, let me pull it up here, share my screen again, is this website that we have launched. It's called quizmd.ai, and quizmd.ai basically helps you generate questions from any information. So you can upload any of your lectures or document. You can upload my presentation into it, and it will just generate questions around it. So what you do is that you give it either a story, upload any document, or give it a summary of a case that you saw, and or give any keywords, and it will basically generate questions around it. So the questions will look like this. This is the information given to it: 84-year-old women with adrenal insufficiency and shaking, and it created these questions which look like USMLE style questions automatically. So let me just show it to you, because otherwise it'll be hard to believe. You can go and explore currently existing questions on there by yourself. This website is open to everyone. This is called quizmd.ai. But I wanted to quickly show you how a question can just get generated. So this, let's take example of our lecture here, right? So we're talking about Parkinson disease and wearable devices. And I'm going to have him generate questions related to Parkinson's disease and wearable devices, which are USMLE style questions. It will take about a minute or so, and then come back and generate these questions for you. All right, so it generated these questions from it. It generated 17 questions out of it. Took about 2 minutes for this to generate. And you can go through, you can generate questions yourself, but just to give you an example, it's simple one-line questions is one approach. Otherwise, it has even clinical cases that it generates for practice questions. You can use it many ways. You can put your old questions that you got wrong to generate new questions out of it. You can upload any of your lectures or documents into it. You can use it for preparation of any test or exam. It is free available. You just go to quizmd.ai and you log in with your Gmail account. So it says login button here or generate now. You use any of your Gmail account to log into this website. There's no cost or charge for it. It will have some pre-generated questions for you to look at to get some ideas on what the questions look like. But you know, generator will be the default, and you can just click start new. This is my history of documents. You won't see it. It will be empty for you. You either upload anything or type some information or copy paste some information here and ask it to generate question. Give it a few minutes. Typically takes 2 minutes to 3 minutes to generate a question, depending on how big the document is. Try to upload small size of document. Don't upload a whole book. You don't want questions from the whole book, right? You want just one chapter or a few pages. So copy paste might be easier for you to just input text here, and it will generate 5 to 20 questions for you, and you can generate more. So once you have done those questions and you're finished with them, you can hit generate more and generate more questions out of it. So thank you so much. I just wanted to share this with you, and I want to thank the organizers for inviting me for this presentation. I'm very excited about this conference. I'm very excited to share with you the things that I'm doing, things that I've learned. And feel free to connect with me on LinkedIn, and I'll be happy to answer any questions you guys might have.